Hello all. Today's topic, what we're going to discuss is bone anchoring hearing implants. And I'm Dr. Ganga Kamath, fellow trainee in skull-base surgery under Bangalore Institute of Skull-Base and World Skull-Base Foundation. And I'm working with Dr. Sampath Chandra Prasad. And let's quickly get back into the topic. And before we know what are the uses of bone anchoring hearing implants, we need to know what are the type of hearing losses we see. So as you all know, we see conductive hearing loss, sensory neural hearing loss, and mixed hearing loss. So these BAHA is more impactful in conductive and mixed hearing loss. So it can help in certain cases of sensory neural hearing loss, especially unilateral or single-sided deafness. So we'll know much about it as we go ahead. So what are the solutions for conductive hearing loss? So we have hearing aid, again, the bone anchoring hearing implants and middle ear implants. And we will be focusing on today's seminar more about the bone anchored hearing implants. So coming to the bone conduction devices, so there are three types. One is the direct drive where it stimulates the bone, and the other one is in the mouth. That's a sound bite is the one what they manufactured, which is placed over the teeth, molar teeth, and that kind of vibrates and conducts the sound to the cochlea. Another one is the skin driven, so which can be the conventional headbands, and passive transcutaneous, which is implanted magnets. So the passive transcutaneous can be SOFO and BAHA attract. So we will come to know more about this in a subsequent slides. So yeah, so we are going to more focus on the direct driven bone conduction devices. So the percutaneous BAHA are BAHA from Cochlear and Ponto, and active transcutaneous implanted transducer, that is Bone Bridge and BCI. So coming to the mechanism, what is BAHA? What is bone anchoring hearing implant? So it is a semi-implantable percutaneous bone conduction hearing device, which is mainly uses the principle of electromagnetic vibrator, which transcutaneously coupled to the osseointegrated implant. So it combines a sound processor, an abutment, and a small titanium implant. So it was first described by Stellstorm in 1981 in Sweden. So what are the companies which manufacture these bone anchoring hearing implants? BAHA from Cochlear, it has two types. As I said, it is the BAHA Attract, which is again a transcutaneous system, and BAHA Connect, which has an abutment, which is a percutaneous system. And Ponto, again, it's similar to BAHA, which is a Oticon company manufactures it. Again, it is a percutaneous transmission. And coming to Alpha 2, which is a Sofono thing, and Alpha 2 is a transcutaneous passive anchoring, bone anchoring hearing implants, and Bone Bridge is again an active transcutaneous hearing implant. So coming to Osia Cochlear, which we will be discussing in subsequent slides, it is one of the latest invention by, I must say, from Cochlear company, which uses piezoelectric. So all the other implants, what you can see here, uses electromagnetic vibrator, but the Osia uses piezoelectric magnet. Again, it's an active transmission. So coming to the principle of BAHA, it is based on two main principles. One is osseointegration and direct bone conduction. So coming to osseointegration, it happens when the titanium fixture fuses with the bone, which takes about 3 to 6 months for the bone to complete the process of osseointegration by stimulating the osteoblast growth. And the second principle is direct bone conduction, which is a stimulation through vibration from sound processor onto the skull. So here's a quick video showing how a bone anchoring hearing implant
how the Cochlear BAHA
works.
Connect system works. The BAHA Connect system uses a small abutment to attach the sound processor directly to the implant.
Abutment and then the implant. So when
the sound processor picks up sound vibrations from the environment.
Through electromagnetic vibration,
the sound vibrations are transferred through the abutment to a small titanium implant inserted in the bone behind the ear.
Implant, which is inserted
the sound vibrations are then sent directly through the bone to the inner ear, or cochlea, where they are converted into electrical impulses.
So coming to the advantages, what are its advantages? Skin is not compressed and vibrations are directly transmitted to bone through screws instead of the bone, preserving the high frequency amplifications. So this is useful when the conventional hearing aids fail to provide enough amplifications. And these devices are worn surgically and non-surgically. And the advantages of especially bilateral BAHA is to pick up the sound from 360 degrees. And it is most effective in skull-based surgeries, especially for post-operative hearing rehabilitation. So coming to the candidacy criteria, who are eligible for these hearing implants? So as I said earlier, conductive or mixed hearing loss, as you can see, especially in children with ear abnormalities such as atresia, microtia, and even in CSOM and single-sided sensory neural deafness and conventional the hearing aid users who have chronic otitis media and who have undergone radical mastoidectomy or have a large myoplasty or blind sac closure because of any skull-based surgeries, and candidates with otosclerosis, tympanosclerosis, canal atresia with a contraindication to repair. So what are the per se contraindications for bone anchoring hearing implants? So one is when the PTA has the bone conduction thresholds worse than 45 decibel hearing loss with speech discrimination score less than 60% in the target ear. So the other reasons can be emotional instability, where there is developmental delay or there is drug abuse, and then there can be general medical condition of the patient which may not permit for general anesthesia, and then patients with relative contraindications such as prior radiation where there is possibility of bone necrosis and osseointegration failure, or when there is inability to follow up or there is inability to clean the device. These are the possible contraindications. So coming to the BAHA system in single-sided deafness. So what are the advantages of implanting a BAHA in single-sided deafness? So most important advantage is it lifts the head shadow effect and it improves hearing in noise background. And it normalizes speech perception and working memory performance in children. So the early language development is helped. And the BAHA system yields high satisfaction in both adults and children. So the possible indications would be single-sided acoustic neuroma, meningitis, and when there is sudden sensory neural hearing loss, or if there's any sensory neural hearing loss with CSOM. So the advantages in children, it's always debated that ideally the hearing implant is not advised in children below 5 years, for the main reason that there can be failure of osseointegration, there can be direct trauma, skin site infection or overgrowth, and the maintenance of the implant would be difficult. And also we've seen that the implant failures are around 5.8% to 15%. However, the most important reason is the bone development. So for BAHA to be successful, the cortical bone thickness should be more than 3 mm. So which is not seen below the 5 years of age. And so ideally it's not recommended. So what do we do when we need the age group which is most important for language and speech development? So we use something called as BAHA soft band. So a soft band is provided and the sound processor is placed. So however, many studies have been done where a few studies it's been successful, where the implant has been done between the age group of 2 to 5 years, but the bone thickness was at least 2.5 mm. 5 mm. And ideally, it is a two-staged procedure, what we do in children. But if the bone thickness is more than 3 mm, single-stage procedure can be done. And yes, coming to the audiological assessment, we need to get a pure tone audiometry to see what is the condition, what type of hearing loss it is, and the tympanometry to rule out any middle ear pathologies. And we need to do speech audiometry mainly to see for the bone vibrator testing and also for ruling out any retrocochlear pathology. So we might need a temporal bone CT scan to rule out any pathologies per se, or in children, mostly in children, to see for the thickness and quality of the bone. So MRI is generally not required, but if you're suspecting any retrocochlear pathology, to rule out that, and also in single-sided deafness to find out the possible cause for deafness. So coming to the surgical steps, so how do we go about it? So coming to the technique, so there are, as I said, there are two procedures. One is single stage surgery, and then one is two-stage surgery, which is staged apart for about 3 to 6 months. So coming to the single stage surgery, the main criteria is you need to have a good bone quality. As I said, the thickness should be more than 3 mm and more than 5 years of age. And however, more and more single stage surgeries are performed nowadays, for the reason we are using BI 300 implant. So this implant is of a good quality, where the torque of this implant, so where the implant gets attached to the bone in such a way that the abutment can be placed at the same setting, and second stage surgery can be avoided. So however, two-stage surgery can be done, as I said, in children, where you have to perform a staged surgery for ossian integration, and when there is compromised or soft bone, irradiated bone, and in conjunction with other surgeries like acoustic neuroma removal, where that itself is a staged procedure, and when there is special needs of the patient, like mentally or physically challenged. So selecting the implant site. So what are the audiological factors? So when there is bilateral hearing loss, you will it is always advisable to have a bilateral fitting, so that you will have 360-degree hearing, better speech perception, and you have better understanding of speech and noise. So unilateral fitting, when whichever ear has a better cochlear reserve, you go in for unilateral fitting. And in single-sided deafness, always implant the hearing bone anchoring hearing implant on the deaf side. So coming to the physiological factors, sometimes there will be microtia, and you might or atresia, and you won't be able to place the implant on the masted cortex itself, and you have to push it to the parietal bone. So in that case, that has to be considered, because placement far from the cochlea can affect the audiological outcome. So parietal cortex, as I said, you might have to do it when there is craniofacial abnormalities, and the implant site might be placed more posteriorly in autogenous reconstruction, such as microtia and atresia repair. So preparations for surgery. So this is the abutment, the Dermalock abutment, BI 300 implant image this is. So it is coated with hydroxyapatite layer. That is the one which stimulates the process of osseointegration, where it is in contact with the tissue and the bone. So the abutment is available in 4 different heights, that's 6 mm, 8 mm, 10 mm, and 12 mm. And it is mainly the abutment site is selected based on the skin thickness. So the abutments are then delivered to the pre-mounted on the BI 300 implant and then placed. So coming to the one-stage surgery. So again, I said it is indicated when there is good bone quality and thickness, and it is a one-stage procedure, and it involves placing implant with a pre-mounted abutment. So these are the surgical steps. I would quickly run through it. So how do you measure it? So you're going to measure it about 50 to 55 50 to 55 mm away from the ear canal. and you're going to place the template, and as shown here, and this is the place where the BI300 implant would be placed on the bone, and the markings are made here, and about 20 to 30 length long incision is made, and beyond 10 beyond the incision side, the methylene dye is injected, so it will be a marker for the BI300 implant to be placed. So once the incisions are done, then you take a needle, and this is done so that we can select the right abutment for the implant. So skin thickness is measured, as you can see here, it's about 5 So once the skin thickness is measured, the rightful abutment is selected, and the skin flaps are developed, and the periosteum is exposed. As you can see here, we had injected methylene blue to the depth of the bone, and it is seen as a reference. And a cruciate incision is made, and the periosteum, the bone is exposed, and using a guide drill. So this is a guide drill. So guide drill, the master bone is drilled. This is how. And once the guide drill is made the sufficient drilling, then a widening drill is used. And once the widening drill is used, you take the, this is the implant along with the abutment. This is for the first stage procedure, complete one single stage procedure. So this is the abutment, and this is the implant, BI300 implant, and that's placed here in the drill hole what we have made. So once this is done, as you can see here, once this is done, a punch hole is made on the skin so that the upper portion of the abutment is brought outside and fixed over the skin. And then the wound is closed, and then the healing cap is placed. So once it's healed, the sound processor is placed. So if it's going to be a two-stage procedure, then how do you end this stage? So once the BI300 implant is placed, then you place the cover screw. So this is the cover screw, what you take, and you place the cover screw over the implant. So in the stage procedure, which will happen between 3 to 6 months post the first stage, you unscrew this, and as you can see, you can unscrew this and then go ahead with placing an abutment, and then punch hole, and then healing cap. So what are the complications we can expect in this kind of procedure? So one is during complications during surgery, the implant can get stuck during insertion. So what do you do then? So the drilling unit has to be kept in reverse mode and unscrew the implant, and then you correct, align it, and then reinsert. So CSF leak can happen if the bone thickness is not measured properly, or it's, when you drill through the bone and you expose the dura, CSF leak can happen. So apart from this, hemorrhage, if you damage the sigmoid sinus or any mastoid emissary vein, which is rare, can happen. So what about the post-operative complications? Yes, so the skin thickness, based on the skin thickness, inflammation and infection can happen around the abutment. There can be skin overgrowth, and there are tendencies for keloids or epithelial inclusion cyst and sebaceous cyst formation. So these are soft tissue complications. So what are the possible bone complications? So as I said, there can be osseointegration failure, where it depends on the bone quantity, quality, and if there's any history of any trauma, infection, generalized disease, and surgical complications where we've done too much of drilling, or per se if there's any skull-based surgery what we've done. So there can be bony overgrowth, and special considerations can be given. As I said, if a patient has undergone radiotherapy, and in MRI there can be any artifacts and osteonecrosis. So coming to the Osia, which is the latest, the newest addition in bone anchoring hearing implants. So I would like to give a few details on this. So what is so special about Osia 200 implant? So the speciality of this is, first, it is an active implant, so which is using piezo power transducer. So earlier the hearing implants, what we spoke was electromagnetic. So this is the first Osia first hearing implant which is using piezo power technology. And in this, the speciality is in the transducer is embedded within the bone, so it's inside the skin. So the outer component contains only the battery, magnet, and the sound processor. So the transducer is fixed inside. And what are the further advantages? So before that, we would just see what's the mechanism of this. So the sound processor captures sound from the air and transmits to the transducer through radio frequency link, and the transducer vibrates to activate the BAHA 300 implant, and then it directly stimulates the cochlea. So coming to the advantages, Osia users show a significant improvement in their ability to understand speech in quiet and in noisy environments. So what are the audiological criteria? It is again the same as other BAHA implants, where airborne gap should be more than 30 decibel and sensorineural element up to 55 decibel hearing loss. So the advantages in the other bone anchoring is the sensorineural element can be up to 65 decibel hearing loss. So what are the potential benefits with Osia system? They can be, the conductive loss is bypassed and ear canal can be left open and nothing is there in or on the ear. So as a result, there is less need of amplification and less aggravation of otitis media and otitis externa. There is consistent hearing even during episodes of ear infection. So the advantages per se of Osia system is it is a simple and straightforward surgery. So it's a simplified coil insertion with no recess required and no risk of coil migration. There's no preoperative CT requirement, minimal master drilling, and minimal risk for dura exposure. So what are the benefits for the patient? So the patient can experience a digitally sound experience, giving the patient hearing of highest quality. And it has a smart sound IQ driven processor which enhances speech, reduces noise, and increases comfort. And it has excellent speech recognition in noise and in quiet background. So coming to the steps of Osia, how do we do it? So this was done in a patient. Let me give you a brief history. A patient who presented with petrous bone cholesteatoma. I must say, I can proudly say that this is the first Osia implantation probably in the Asia Pacific, which is done in a skull-based surgery. So the patient presented with petrous bone cholesteatoma, and we planned for a transcochlear removal of petrous bone cholesteatoma. The patient also had facial nerve palsy, for which aesthetic facial surgery was done. That is and Osia implantation was done as well. So here's again the template marking which is done for Osia. This is the unusual way because large mastoid cavity was done for the sake of surgery. It's a transcochlear approach. So coming to the template marking, once the template marking is done, again here the skin thickness is we are injecting a dye for the BAHA 300 implant drilling, and then this is the transcochlear approach. What we've done, complete disease clearance is done, where the facial nerve we couldn't say because it was a grade 6 facial palsy. This is the cut end of facial nerve. What you can see here, this is the carotid artery, completely skeletonized, completely exposed, and yes, as you can see here, there's complete disease clearance achieved. Yes, the internal auditory matrix is completely drilled out. So if we would have drilled this part of bone, we would have entered the sphenoid sinus and down here to the clivus. So this is the picture, and this is the parietal bone where we plan to place the implant. So the template is again kept, and here the bone is drilled again with the widening drill, guide drill and widening drill. And once the bone is drilled, before placing the implant, in this step, what we use something called as bone bed indicator. So what are the advantages? Why this bone bed indicator is a must? So what happens, since this is a piezoelectric active process, the transducer should be placed directly in contact with the BI300 implant. So if that doesn't happen, and if it comes in contact with the bony surface, the efficacy of the implant reduces. So it is a must that you have a smooth surface along the around the BI300 implant. So this helps in assuring that the surrounding area of the BI300 implant is smooth. So it's called as bone bed indicator. So where you turn it 360-degree and you see if it goes to the bone smoothly. So if there's any obstruction, then you have to drill the bone and make it smooth. So once that's done, we are fixing up the BI300 implant. And then this is how it's seen once it's secure. And this is the Osia 200 implant, the transducer and the magnetic coil with the screw. So we are fixing it to the BI300 implant. And yes, so once this is done, and we close the cavity with abdominal fat. And this is how it looks. And then in about 3 to 4 weeks, which is the minimal time required for the wound to heal, we then fix the sound processor. So this is about a brief webinar about bone anchoring hearing implants. Thank you. Any questions? Thank you so much.